on behalf of the American Healthcare Association and NCAL. My name is Gail Clarkson. I am Chief Executive Officer of MediLodge. Our 14 skilled facilities and 4 assisted living facilities employ 2,500 individuals and care for more than 2,300 patients and residents in the state of Michigan. I have worked as a nursing home administrator, director of nursing, and an intensive care nurse. I know what it takes to provide high-quality care for seniors and people with disabilities, even when the payments do not cover the care and services they require. I mention this because Medicaid underfunds long-term care by approximately $13 per day nationwide, and because quality depends on stable funding, something CMS has repeatedly acknowledged. Most nursing home patients are both poor and elderly, relying on Medicaid and Medicare to pay for their long-term care. So nursing homes have worked long and hard to coordinate care for these duly eligible patients and residents to ensure that these vulnerable Americans get the best care available. ACA and NCAL continue to work closely with CMS on Medicare Part D. I am proud to say that no patient or resident being cared for in a skilled nursing facility went without his or her medication during the transition to the new prescription drug benefit. I do not know if the same can be said for the other poor elderly. Duly eligible beneficiaries in assisted living or residential care facilities or other home-like settings have only a small personal needs allowance of a few dollars a month, so copays of even $1 to $3 can add up when that person needs multiple prescriptions. Like nursing home patients, assisted living residents need on average of approximately 9 medications a day. The Home and Community Services Copayment Equity Act, recently introduced in the Senate, would eliminate Part D copays for these low-income Americans and would put duly eligible home and community-based individuals on par with those in nursing homes who have no copays under Part D. We urge the members of the committee to enact companion legislation. Programs like Medicare Part D and low-income subsidy are critical parts of the health care safety net in this country. But what I have found in practice is that accessing these programs can be challenging, as was with the case of the auto-enrollment of the duly eligible nursing home residents under Part D. For example, we spent considerable time and effort identifying which Part D plans patients had been automatically enrolled in and determining whether or not that plan met that patient's needs. ACA and NCAL worked with CMS on what it calls a 3-pronged approach to assure that the poor elderly entering a facility and needing prescription drug coverage could access their benefits under Medicare and Medicaid. Our experience shows that low-income subsidy can take effect in only a couple of weeks, whereas it can be months before Medicaid eligibility is determined. But in my experience, I have found that patients, families, and healthcare providers are unaware of these benefits or even know how to Medicare and Medicaid works in long-term care. So we must educate and assist patients in accessing these critical benefits. ACA and NCAL understand that retrofitting a new benefit is not that easy. That is why we have looked at ways to reform Medicare and Medicaid to better meet the needs of the swiftly aging baby boom generation. Our recommendations are included in my written testimony. Providing high-quality long-term care is a top priority for me, and ACA and NCAL members like me who are participating in the national campaign to improve quality of care and quality of life for our patients, residents, and staff alike. We are proud of our commitment to quality and are proud the data is proving our commitment is real. Nursing Home Quality Initiative data shows improvement in pain management, reduction in restraints, decreased number of patients with depression, and improvements in physical conditions such as pressure ulcers. Last week, an independent satisfaction data was released that shows 82%, the vast majority of nursing home residents and families, would rate care as excellent or good. Even as we strive to deliver the best care possible, we still face considerable challenges and seek your assistance in meeting those needs. We are working to be transparent for our consumers. We ask that CMS be similarly transparent in the criteria it uses to oversee the care we provide. We also ask that CMS not place paperwork over patient care, and thank Chairman Dingell and those who have already called on CMS to redress its final rule on blood glucose monitoring. We are proud of our successes and acknowledge there remains far more to do. Mr. Chairman, I have never seen our profession more committed to ensuring we continue to improve quality care. In short, we recommend working towards a system that delivers an array of long-term care services that is adequately funded, administered by knowledgeable, quality-driven providers, and where beneficiaries move more seamlessly through a long-term care spectrum, which every American is likely to need at some point in his or her life. ACA and NCAL stand ready to work with your committee and with all who have a stake in the future of the long-term care delivery system in the future. Thank you.
Thank you, Ms. Clarkson. Dr. Payne?